Good afternoon. Thank you for joining us at AIG Hospitals, Gachibowli. We are here today to discuss about how we can save lives in accidents. On the panel, we have myself. I'm Dr. Srinivas Thati, Director and Head of the Department, Trauma and Orthopedics. Dr. Medha is our Emergency Medicine Physician, and Dr. Sangeeta is our Trauma Care Intensivist. Accidents in our country are very common. We see 1 in 4 deaths every minute. There are almost every 4 minutes there is 1 death due to accidents in our country. And also there are 53 accidents every minute. That is not surprising because of our population and lack of traffic regulations in some cases. But here we are to discuss about how we can reduce deaths in road traffic accidents. So I request Dr. Sangeeta to give a brief on what are the immediate things we can do to reduce the deaths in accidents. Dr. Sangeeta, please.
I would like to talk about that as doctors, what do we do when we receive a patient with accidents? So accidents can cause a variety of injuries. It can be mild, trivial injuries. The patient may just need an initial assessment, or the patient can have severe injuries, which if not treated or addressed timely, it may cost his life. It may cost severe disability, or we may miss some life-threatening injuries. So in order to avoid these problems and to do our best for the accident victims, one important reason why is because majority of the accident victims are from the younger population. They are the breadwinners of the family. The most active age group are the usual victims of trauma. So it's very important for us that we do whatever best we can to restore them, to bring them back to their normal life. So what we do is, whenever we get a patient with polytrauma is someone who has multiple injuries, 2 or more multiple injuries involving the major organ systems. So when we get a case of polytrauma, when we see a patient, so our major priority is, first thing we have to keep in mind is, are there any injuries which are immediately life-threatening? So my first thing would be to identify, are there any life-threatening injuries? And if yes, I'm able to identify and I'm seeing something, then immediately we have to address these injuries. We have to manage and treat these injuries so that we can reduce the risk to life. So for this, we have a lot of surgeons initially all over the world, especially the standard institutes, the American Institute especially, they have laid down and they worked upon the standard guidelines which are followed all over the world, and which we also take training and we repeatedly follow those guidelines and protocols. So it's like a structured, protocolized way, which we say it as the primary survey or the ABCDE approach. So this helps us without much thinking. In this ABCDE approach, if you follow this algorithmic pattern without much having to waste time on thinking, immediately majority of the injuries are recognized and taken care of. So what is this primary survey? It's a very easy way to remember if you see to it. So A stands for airway, breathing, circulation, D for disability, and E for exposure. So as we go ahead with our talk, we'll be talking about each of these components. We'll be explaining it to you how we start with it and how we go ahead dealing with injuries and how we manage the patients. So to carry forward, Dr. Medha would like to discuss with you airway and breathing related problems and injuries.
So when it comes to airway, which is the most important part in saving a life of a patient, any patient, so there are few problems that are related with airway. So when you classify the patient into two types, first is a conscious patient and an unconscious patient. So when we take a conscious patient, looking at the patient, when you talk to the patient, you will get to know how the airway is. You can assess the airway. If the patient is able to answer you, if there are no added sounds, if he's able to talk freely, that means his airway is patent. So if you think there is any grunting sounds or any added sounds, then you think there is some obstruction. In trauma, there can be always a chance for his own tooth, or when there's a facial injury, to fall back into his throat. And there can be always foreign objects that can always obstruct the airway. So when things are there like that, we'll tell you what we have to do. So majorly by talking to the patient, you will get to know if the airway is intact. When it comes to the breathing part, so the problems associated with breathing can be many. It could be because of the upper airway, or it could be because of the major organs that are involved. So when you say the main components of breathing can be starting off with your nose and mouth, the next will be your throat, which we call it as the pharynx. The part of your voice where it comes out from, it's the larynx, and then your trachea followed by your lungs. So there can be many problems associated which can obstruct the breathing as well. A few conditions in trauma where you can obstruct the breathing can be, or problems related to breathing can happen, are things like pneumothorax, hemothorax, that can be a cardiac tamponade. So these I will tell you what they are in clear. So when it comes to a cardiac tamponade, what it is, that the sac around the heart, so when there is a fluid filled around the heart and your heart doesn't have the capacity to pump properly, so your circulation is at fault, so then it is called as your cardiac tamponade. So we need to release this immediately, which we will discuss in circulation. Next, when you come to your lungs, it can cause hemothorax, it can cause pneumothorax, it can also cause an open pneumo. So as I said, there is a pleural cavity that is there in which your lungs are put. So the gap which is there between the lungs and the pleural cavity, there it can be air filled, or it can be fluid, or there's blood. So when this is there, the lungs are not expandable. They cannot expand to the maximum extent, and your breathing will be obstructed. So when these are there, we will further tell you what protocols to be followed. We will have to do, we have to put a drain, we have to go ahead with when there's an open pneumothorax, we have to go ahead with a 3-way bandage dressing, all these. So first is your initial recognition. When you recognize a problem, you'll have to treat it immediately. And when it comes to an unconscious patient, the major thing that is, his own tongue can fall back. So when the patient is not conscious, his tongue can fall back and causes airway to obstruct. So then we will be using few airway adjacents, like an oropharyngeal airway or a nasopharyngeal airway, depending on that. There can be pooling of secretions in facial trauma, where the own blood of the patient can be pooled in the trachea. So depending on that, we will be using all the required adjacents, and we will be transferring the patient to the hospital, doing the procedures on the priority basis, and then saving. So
that's a detail about the airway and breathing. When it comes to a roadside resuscitation, there's a distinct difference when you see a patient on the roadside and when the patient comes to an emergency department. What can be done immediately on the roadside to get the airway working?
Okay, so when it comes to the when you see a patient lying down on the road when there's a accident, the first main thing that you have to see is, if you think the patient is having some blood that is getting collected in the throat, the basic thing that you can do is turn the patient to the left lateral position so that he doesn't aspirate. The airway can be put clear. So putting the patient in the left lateral position is the first thing that you have to do. Then if you have any foreign objects that are clearly visible, then you can just remove them. But if you think they are a little deeper inside, please do not go ahead with manipulating them, because you may push them further inside, and that can cause further obstruction. So these are the two main things in airway where you can save the patient initially.
Well, I think before we do anything, we need to rule out a neck injury.
Yes,
so,
yes. So
ensure that the neck is not
stabilized.
moved, especially in patients people who have accidents.
Yes.
Because that can cause more injuries as well.
So if we suspect there's any trauma to the head or to the neck or to the upper back, then we have to stabilize the patient. We cannot move the patient as it is. So we have to stabilize the patient, we have to stabilize the neck, and then only we have to go ahead with any other maneuvers.
I think once we see a person having an accident and has breathing difficulty or blockage in the airway, I think the key is not to waste any time. Apart from doing the intervention, if a person who is trained in doing the basic life support, they can do the minimal intervention but get an ambulance quickly so that the person can be transferred to a nearby hospital. It doesn't have to be any bigger the hospital or setup. Any close by hospital where they can do a basic life support should be adequate.
At this point, one important thing I would like to stress is, as a first responder, suppose if there is an accident victim, as Dr. Mehra has already said, the patient is conscious talking to you, you know the airway is intact. So why we are worried so much about this airway and breathing is, so basically the airway and the lungs, they are the major structures responsible for maintaining the gas flow in and out of the body. So everybody I think knows, no oxygen, no life. So if my conduit which gives oxygen to my body is damaged, then it is a severe life-threatening condition. So that's why airway comes as the first priority, because you want to maintain the in and out flow of the gas, of the oxygen and the carbon dioxide. Also, one other thing I would like to stress upon is that if the patient is unconscious, try to see whether there is a pulse. So most of us, I think these days, most of us have been going through and attending basic life support training. So if you are a BLS trained certified person, you know anything about chest compressions, please see whether the patient has a pulse, and if he does not have a pulse, go ahead with chest compressions. If you don't know how to give chest compressions, you don't know basic life support, then don't do it on the first time on that patient. Try to ask help, try to ask somebody around who knows something, and try to get the ambulance as fast as possible.
I mean, that is a key aspect, right? The basic life support training is available in a lot of places now, and most of the places do free of cost, and it's a very important life saving protocols which when you correctly follow. But if you're not aware of them, better not to waste time, get help quickly and get the patient moved to the nearby hospital quickly. So when it comes to these patients, patient management, when they get to the hospital or in any emergency department, then we do have the basic equipment which is required to get the airway, like Dr. Mehra was talking about, the cannulas,
OPS.
These can be used quickly, and as a trained emergency physician or a trained trauma doctors, we can get this done as soon as possible. What is the average time we can get these patients with any of these airway or breathing problems resuscitated?
It'll hardly take us less than, I can say, 120 seconds.
So
less than
hardly
120 seconds to
less than
maintain the airway.
2 minutes to
Less
get
than
the
2
airway
minutes
working.
airway working.
At the same time, the breathing part. So as Dr. Mehra already elaborated on, the problems which can cause life-threatening issues are air in the lung, like a pneumothorax between the lung and the lining of the lung, hemothorax where there's blood in the lung, in this space. So what do you do for pneumothorax, or and what is tension pneumothorax?
Yeah, so basically, as I have already said, when there is air, when it's called as a pneumo, and when there is blood in the sac, it is called as a hemo. So to get that out, we have to use something called as an ICD. It's an intercostal drain where we have to place it, which it exactly lies in the sac, which drains out the air or the fluid. When we do that, the lung has enough space to expand, as lung is like a balloon, so it'll have enough space to expand and take in the gases for exchange. So once that's there, we can see the patient returning back with all his normal vitals immediately.
Yes. If for example the patient is far away and a first responder has noticed that something is going on and patient is not able to breathe, if they know that there's a pneumothorax, is there any simpler thing which they can do? on the
We
roadside?
do not suggest people who are not trained to do it. All they can do is first initially call for help. The ambulance or the local hospital, whichever is nearby, and immediately start the patient on oxygen. That is the basic thing where anybody can do it. So after that, the paramedics and all, we can do a needle decompression and everything till we get the patient to the hospital. So if you find a patient lying down, and if you think, there will be few signs where you can see that the patient has issues with breathing. You can see his consciousness is decreasing rapidly. He's getting cyanosed. Cyanosed is when your face, your peripheries turn cold and bluish. So these are the signs when you know that there is some obstruction or there is some problem associated with breathing. So I suggest you call for help immediately, and once they come, first thing you can do, a basic thing, is start the patient on oxygen. So that will help us.
And coming to the next part is the circulation. Circulation is basically maintaining the blood volume in the body, and a lot of these trauma patients can lose blood either in the lungs, in the abdominal cavity, in the pelvis, or because of any limb injuries as well. And when we look at all the deaths which happen after accident, we call this as a trimodal distribution. They happen at three different phases. The first pool of deaths happen immediately. That is mostly because of a massive head injury or a brain injury. And the second phase of deaths where we see is because of circulatory issues mainly. And that period is called golden hour for us. If a person who had an accident can be taken to a local hospital quickly, this as soon as possible, this time will save the life. The earlier we get the person to a hospital and initiate the airway maintenance or breathing, getting back the normal breathing, and identifying the circulatory issues and checking the blood pressure, heart rate, and if there is blood loss, immediately we start on IV fluids, and we do a grouping and cross matching to know what group the blood group is the patient's, and arrange for a blood transfusion as required. And this takes a very important this is a very important step in saving life of patients who have circulatory issues. So already we talked about a hemothorax where the blood gets collected in the chest. Are there any ways where we can identify blood in the abdomen or any bleeding happening in the pelvis?
Yes. So as Sir has already mentioned, that bleeding is a major complication, and at times it's the foremost cause of death. Exsanguination is the foremost reason why sometimes these patients may die before reaching the hospital. So in this golden hour, what we have mentioned, even in that period, there may be some bleeder, patient may be having low blood pressure, there are some injuries which are not taken care of. So how do we identify them? We do something called as clinical examination, of course. As soon as the patient comes, as Sir has mentioned, we check the vital parameters, we start them on fluids, we start them on blood. But if still there is ongoing bleeding, then we need to look, identify and stop quickly. So for that we need to go ahead and do investigations. So we have been trained and we have equipment to do quick rapid assessment within a few minutes, less than 5 minutes. We can do what is called as a fast examination. So basically it's ultrasonographic rapid examination, wherein we try to identify blood in the body cavities. So there are hidden areas where we cannot see the blood loss, but internally the patient may be bleeding. So this blood internally in the thoracic cavity, around the lungs, the cavity around the lungs, in the abdominal cavity, for example, if the patient has a liver injury, a splenic injury or bladder injury, he may be bleeding inside. So these injuries and blood loss can be identified in less than 5 minutes with rapid ultrasound assessment. So, and then next we can further plan our course of action. So we need to identify the exact location. We may go ahead and do the CT scan if time allows us, but just by identification of the presence of blood and the patient is very sick, we may need to take the patient urgently to the operation theater to control this source of bleeding. So in this way, by this algorithmic approach, we can tackle major circulatory issues.
The other two important things which we can do to control the bleeding, especially in patients who have a pelvic fracture, is applying a pelvic binder. So it doesn't have to be a properly made pelvic binder. You can use a sheet around the pelvis and tie it around the prominent part of the hip bone. That way, the pelvic volume will be reduced. When the pelvic volume is reduced, because of the compression, also the bleeding will stop. That's one of the simple steps, but it can be life-saving as well. And in patients who have any open cuts in the long bones, like a crush injury of the leg, the simpler thing is to apply a tourniquet around the proximal to the injured area. This you can either use a sheet of a towel or something, whatever is available immediately on the roadside. But once they come into the hospital, then we do in a proper way, where we transfer the patient appropriately without causing any further damage, and then we apply a pelvic binder. Then we'll follow the clinical examination from A to E to complete a thorough assessment. And in level 1 centers like us, we have the facility of having a CT scan immediately, and all the latest studies does show that getting an early CT scan, we will be able to identify the injuries more precisely, and we can plan the treatment quickly as well. And with the circulatory component, sometimes we may have to do massive blood transfusion, where the entire blood maybe need to be replaced. Whichever is lost need to be replaced, and the priority remains is, one is first to replace the blood, and second thing is to stop where it is bleeding from. These are very important aspects in circulatory component of the ATLS protocol. The next is disability, and Dr. Sangeeta will explain more about disability.
So disability means examining the neurological system. So majority of the times accident victims, they may have injury to the head, and head trauma is dangerous because injuries to the brain can be devastating. It may cost the patient his life, or it may compromise his quality of life. He may be become disabled or bedbound. So head injury, two important things that I would like to state here is, whatever the accident trauma or the impact had caused, that is called as primary trauma or the primary injury to the brain. And as first responders or the EMS responders, or as doctors, our duty is to prevent any further secondary injury. Whatever damage has happened, that can be brought down, that can be mitigated, or that can be improved upon if we know and do certain things which can prevent secondary injury to the brain. So brain injury can be mild to moderate. Mild injury, it means it can be small areas of bleeding or small injury to the tissue structure of the brain. Sometimes it can be very severe, like there's a big area, large areas of the brain that have been damaged. There's collection of blood for which they may need to go for emergency surgery for evacuation of the blood clots. So head injuries can be various types. So preventing secondary injury means that the brain which is now compromised should get support of the vital parameters. If I try to maintain the airway, breathing and circulation, which means if I try to maintain the oxygen levels in the blood pressure of the patient, maintain the airway and ventilation. So this would help the brain to recover and prevent secondary damage. So head disability basically means to assess the severity of the head injury, to do an immediate CT scan if the patient has a head injury, and if he needs an immediate surgery, rush him to the operating room.
Thank you. So among all the 5 ways, the last one is the exposure. Exposure is basically we have to open up and check from top toe to head to toe to see what are the different injuries, and if there's any thing which can be dangerous to the patient, we can take it away. And then reassess going into a secondary survey once a proper primary survey is done. So essentially the 5 ways we are talking about how we can save life is a thorough ATLS protocol, in which A stands for airway, B stands for breathing, C is circulation, D is disability, and E is exposure. When we follow the correct protocol, we can save a number of lives, and that golden period or golden hour is very important. So any person who has any polytrauma or road traffic accident need to be assessed thoroughly. If you are able to provide a basic life support, you can provide on the roadside, but best to get them to a local hospital where the resuscitation can be initiated quickly. And what is the importance of the trauma centers, Dr. Sangeeta, now?
Yes, so it's what, if you go through the studies and the literature, what is important that saves the life of polytrauma patients and what helps them to recover to the best possible end is that we have a center where there are multiple specialty doctors available, and there are equipment available for immediate diagnosis and treatment. So we as an AIG hospital, we are having a level 1 trauma center. So what does it mean? It basically means that we are capable of managing all types of injuries, all whatever severity it may be, all types of injuries we can manage, and multiple specialities, different specialities consisting of an emergency physician, an intensivist, an orthopedic surgeon, a neurosurgeon, and specialities like CT scan and an operating room. All of these facilities are available 24/7. So no precious time is lost in resuscitating and managing these patients.
One important aspect of our trauma center is it is especially created in such a way that we don't lose any time. So once the patient comes through the reception into the trauma center, we take them straight into an area called resuscitation bay, where all the 5 simple ways by which we can save life, we do all of them by doing a primary survey. And if the patient needs anything like a support, ventilator support, we have a 9-bedded ICU next door, immediate to the resuscitation bay. We can take them into the ICU and stabilize the patient on there. If the patient needs any surgery, next to our ICU is the operating theater. So as we have all the specialties which deal with polytrauma cases, the doctors are always available 24/7 in our trauma center. So we can do these procedures in a very short span. Even if the patient needs a CT scan, we have within 2 minutes from our emergency room, trauma emergency room, we have a CT scan available, and that can be quickly done, identify the injuries precisely and get them back into the ICU or take them into the operating room. So this saves a huge amount of time in dealing with these cases, which has a great impact in how we save their lives. So we are proud of having such a facility which is created at AIG Hospitals, Gachibowli, and we have all the required resources. For example, when we do the initial assessment like fast scans and ultrasound scan is available, we have a very advanced X-ray machine which produces immediate images straight away, just like a photograph, and the CT scan. Then we do have other gadgets which are required in monitoring the patient. So what are the things you do in trauma critical care, Dr. Sangeeta, for these patients?
Yeah, so when in the ICU, basically we take care of patients after the initial resuscitation in the ER bay after doing a primary survey. If the patient is sick, then he needs ICU management. So these patients are immediately taken to the ICU area. And most of the times, the initial period, the ICU care that they need is, they need management of blood pressure. That is, they may be having hypertension, which is also called as shock in medical terms. So they may need ongoing treatment, resuscitation to bring up the blood pressure and to maintain the blood volume status. So they may need large volumes of blood, as sir has mentioned. and multiple blood products. That needs to be carefully managed because they need a combination, and in it, like all the blood products, it may be like the PRBC, the platelets and the plasma. So these are all the different kinds of blood products, and these may be needed number of bags for these patients. So they have to be given in a carefully monitored way. Repeated blood tests may be done. And second most important thing is these patients may be on the ventilator. They may be receiving invasive mechanical ventilation. By that, what I mean is, usually what we do is a tube is put in the patient's airway and the trachea, that is the windpipe, so that the breathing function, the ventilation function, instead of the patient, it is done by a machine which is called as the mechanical ventilator. So this ventilator maintains the oxygenation and the gas flow to the patient till the patient's own body and the lungs, they are able to do its own function and they recover. This machine supports it. So these patients are very critically ill patients. They need minute to minute monitoring, recording of the vital parameters, and they may need immediate treatment if any sudden complication arises. At the same time, some of these patients may need immediate surgery. So we are preparing them and stabilizing them to go to the surgery. As sir has mentioned, we have an adjacent OT to our ICU. So immediately we stabilize the patients, we try to arrange things, and they are taken to the OR. And sometimes post surgery, these patients may need a prolonged ICU stay. They are still recovering from their injuries. There are some complications which may need just time. The patient takes time to heal, and vital organs, the vital parameters, they take time to stabilize. So monitoring and management in the post-op situation also is done in the ICU. At the same time, they are prone to many complications in the post-op period. Critically ill patients, major injury patients are prone to many complications, like they may be ventilator dependent for a long time because of head injury or major internal organ injury. They may still need blood products. They may develop infectious complications which need to be monitored and addressed quickly. So for all these purposes, they may have a prolonged ICU stay, and that is why critical care management of these patients is a very important aspect.
So the average time a polytrauma patient spends in ICU is can be more compared to any isolated limb injury patients. So the reason why we treat the patients in ICU is for the reasons what Dr. Sangeeta has informed. They may need ventilatory support, they need regular monitoring, they need blood transfusion, and also post-surgery or post-stabilization, the trimodal distribution I was talking about before, the third peak of death happens post resuscitation at a later stage. That can be because of multiple organ failure, or it could be sepsis. So in the ICU, what we try is, we try and manage or minimize the further injury to the other organs and also prevent the infections. So in summary, the people who have a road traffic accident with multiple injuries, their death rate can be reduced when we start treating them appropriately, but the treatment should be started as quickly as possible. And these 5 ways, the ATLS protocol we follow, is very important in achieving that. So at AIG, we are all equipped with the required resources as well as the specialties we have in dealing with these kind of injuries. Any questions we have?
None, sir. None, sir. None. No.
Okay. Anything you want to add, Dr. Mehta?
So, as we know, right from childhood, we have been taught prevention is better than cure. So, please wear your seat belts, please wear your helmets, please drive slowly, and be safe.
Follow the rules.
Follow the rules.
Please follow the rules.
Yeah, that's well said. A very good way to conclude. Prevention is the best key.
Yeah.
Thank you. Thank you.
Thank you.
Thank you, sir.